So it is great to see so many friends. It's really an honor. I feel so lucky to be here in so many ways. I mean, I did start out driving an ambulance in Somerville, Mass., which is how I got into healthcare. I saw how bad the care was 2 miles from where I grew up, just off Brattle Street in Cambridge. So I got the best care in the world with T. Barry Brazelton as my pediatrician. Saw the worst care in the world, 3 miles away. So went to medical school to think, gosh, maybe I could get involved in that someday. And get involved in health policy someday. So it's pretty amazing to be here and go, oh shoot, what have I done? But I want to start by talking about my daughter, Kate, who many of you know. Kate is 22, has serious bipolar, has probably been hospitalized 15 times. And her experience, our experience, is of communication that is frequent but meaningless and useless from the providers who are involved in her care. When she goes into the hospital, there is no understanding of what medication she's on, even though her providers are 100 yards away in the outpatient wing. The communication is ineffective. Although she can manage it pretty well, she is able to take care of herself, but she notes she's often the care manager on the ward for the other patients who are hospitalized, the uninsured patients who are prescribed by the team atypical antipsychotics that cost $15,000 a year, but the patients are uninsured. What's the team thinking? So the level of understanding and fragmentation that these patients are experiencing really is appalling, especially, and I think it's probably not worse in mental health, but when it's your daughter, you're more upset about it. So the issues of relationships, communication, and fragmentation in our care system are just so apparent to Kate, who's wonderful, still alive, gave me permission last night to talk about her today. But it's been a close call a few times. So the problem isn't very hard to find. If we look back to Crossing the Quality Chasm, the discussions about the terrible fragmentation, lack of safety that many here are working on. So we knew about that problem. The recent work by Brent James and his team, using a more careful way of tracking down, looking at safety, their estimate is 1/3 of hospital admissions have a serious safety event that happens during that stay that causes someone to be at risk of real harm. So we're not doing very well in the 15 years since the Chasm report was published. And then we got this problem. We know it's hard to look at an election 3 days away or 5 days away with the fiscal cliff looming. The fiscal cliff is Medicare and Medicaid. The fiscal cliff is the rising cost of healthcare. If we could keep healthcare costs flat, the deficit would go away if we could grow it at the rate of the GDP. It's not just federal spending. This is colleagues at Brookings put together the total state budgets. I think these are 2011 and 2012, where during the course of this year, for all 50 states combined, spending on health care went up by, God, my glasses don't work very well, about $15 billion for the cost of health care to states, whether it's employees or the Medicaid programs. And spending for K through 12 went down. Spending for higher ed went down. I think the only thing that stayed level was prisons, which is not a very encouraging finding. How many here from Boston? Quite a few. You probably remember this report that got some publicity a year ago by the Boston Foundation. Boston Public Schools in the year 2000 approximately, decided that they wanted to markedly reduce disparities in public education, especially in the high schools. They decided to invest $1 billion in additional funding for the schools in Boston. They did spend $1 billion, but guess what they spent it on? They spent it on us. $700 million on the rising cost of healthcare benefits for the employees of the school district, which made them increase class sizes and cut back on teachers' aides. So, the bargain was not kept. So, it has been such a treat for me to be here at Dartmouth. I came here in '86 to join Jack Wenberg, who looked at variations in spending and variations in practice in the state of Vermont, found tenfold differences in the rate of surgery across these identical lily-white, truly lily-white, it was 1%, non-white population in Vermont at the time. It's now up to 2, so we're getting much more diverse. So tenfold differences in rates of surgery, twofold differences in spending, and a whole group of us have come here, many here in the room, to work with Jack to say, what on earth is going on? What's happening with these variations in practice? The variations in surgery rates led to the insight that patients we didn't know what we were doing with most things. So the adequacy of the evidence to decide what treatments worked and didn't was pathetic. But most importantly, we weren't engaging patients in making choices that were aligned with their preference. So we have both clinical information problems of getting better clinical evidence, but much more important, challenges of getting preferences aligned with the treatments with treatments aligned with the preferences of patients. And we were just talking at our table about amazing innovations in shared decision-making done here in the Psychiatric Research Group, Psychiatric Research Center, helping patients with serious mental illness become empowered to engage in good conversations with their providers around what medications they want to take. Doc, I don't mind my voices. I hate feeling drugged. And empowering patients to have those kinds of conversations has been tremendous. What I focused on when I got here was this issue of variations in spending. You look across the country, it's about twofold differences in spending, not really explained by differences, a little bit of it by differences in price, not much of it by differences in health. So there, between the dark green areas on that map and the pale areas on the map, there's the higher spending regions spend about 60% more per patient than the lower spending regions. And we thought, God, that's an interesting question. As a bright-eyed, kind of bushy-tailed resident or fellow, I thought, gosh, we're probably denying all sorts of beneficial care to those people in the pale areas. So we embarked with the support of the Robert Wood Johnson Foundation in trying to understand what's going on. What are the differences in the content, quality, and outcomes of care across the regions of the United States, according to their spending levels? We studied heart attack patients, colon cancer patients, hip fracture patients, a representative sample of the Medicare population, and asked ourselves 3 questions. First, what's the additional care they get? Where is all that money going? We divided care into sort of 3 groups of kinds of services. Effective care, evidence-based practice, where that 100% of the patients should get that particular treatment. If I'm having my heart attack, I'm hopeful that one of you guys will haul me over to the emergency room and I'll get a stent within about 20 minutes, if we're lucky, certainly within an hour. That would be an example of a treatment that everyone should get. There's nothing about patient preferences unless you're in your last days of life, in which case I don't want you to take me there, but for the moment, my preferences are to go there. But higher spending regions don't spend any more money on those things. In fact, they were able to deliver them a little less effectively. Second category of kinds of things we looked at are, referred to at Dartmouth as preference-sensitive care, elective major treatments where patients' preferences should influence the choice. Bypass surgery, in most cases, is a choice between, we know it's going to reduce your angina. It's not going to extend your life in most cases, and it comes with a side effect. First, your chest is going to hurt like hell for 6 months as that mediastinal incision heals. But then about 10% of patients have cognitive impairment as a consequence of being on the pump. So the choice is, do you want to play tennis, or do you want to remember your daughter's name? And that was supposed to be funny. So, oh God, maybe it's too depressing to be funny. So anyway, tenfold differences in surgery rates across the country, but the higher spending regions weren't providing people with any more of those things. Orthopedists and cardiac surgeons happen to locate themselves in the mountains of the Intermountain West where there's good skiing, and it's a relatively low spending region. So all of the additional spending was on how much time people spend in the hospital, how frequently they see a doc, generally specialists. And of course, if you're horizontal and seeing physicians more frequently, guess what? You get more tests, more imaging. That's where all the money was going. And we weren't getting any better outcomes for it. no matter what outcome we looked at. So survival, no better, function, no better. Docs queried about whether their ability to coordinate care, it was worse in the higher spending regions, their perceptions of their ability to coordinate care. Communication, their perception of the quality of communication among physicians was worse in the higher spending regions than in the lower spending regions. And patients didn't think it was any better either. We spent a lot of time after we came up with the finding that we're wasting about a third of US healthcare spending on avoidable, unnecessary care, trying to figure out, so what gives? Why are we doing so much more in those high spending regions? Part of it is capacity. So these are regions that have 30% more hospital beds per capita, 75% more medical specialists per capita. And so that's important. If an aside, in spite of 30% more hospital beds per capita, the docs say it's harder to get your patients into the hospital, are more likely to report, I can't get my patient into the hospital. In spite of 70% more specialists, they say it's harder to get your patient in to see a specialist. So all those people who do quality improvement in flow will think, oh, this is something about flow. This is about how they schedule patients. The answer to a perceived scarcity is not necessarily to train more physicians or build more hospitals. So capacity turned out to be important, but it only explained about half of the differences across regions. The payment system clearly couldn't explain it on its own because we were really looking only at fee-for-service payment everywhere. Malpractice turned out to be important. It explained about 10% of the state-to-state differences in spending. So we don't want to ignore malpractice. We want to do something about it, but it doesn't explain most of the difference. We use clinical vignettes to try to understand how are docs thinking about these things. How are they thinking about evidence-based practice? And how are they thinking about more discretionary or gray area decisions? And the high spending on evidence-based practice, there were really no differences between high and low spending regions. Docs disagree, but how they make a decision on evidence-based practice was completely unrelated to per capita spending. But those gray area decisions, things like, for a patient with well-controlled high blood pressure, when would you schedule the next visit? Wonderful question. In our focus groups in Oregon, the doc said, oh, every 6 months, maybe once a year. How many people would say, I won't ask you guys. In Miami, they said every month. In Miami, they said every month. Philadelphia, when I visited there, they were so proud of themselves. No, we do those every 6 weeks. There were about 20 other decisions like this. When should you admit someone to the hospital? When should you refer to a specialist? When should you order high-cost imaging? All of those decisions, evidence-based practice is going to help at one little corner of it, and on the low end, and one little corner of it on the high end. But all those decisions are tough decisions that we have to make as individuals managing the patients who are in front of us. And they all held together at the individual physician level as a measure of propensity to do stuff when you don't know what to do. The last piece of the puzzle was, well, why are those things clustered geographically? Because you can't explain that map without realizing that those attitudes toward doing more have to be clustered geographically. So I happened to be at a meeting with Don Berwick, and I said, look, we got this really interesting thing going on here in McAllen and El Paso. They both started out in 1992 at exactly the same level of per capita spending. And by 2006, McAllen was spending second only to Miami. It had had a growth rate higher than any other place on the planet. But El Paso had grown just at the rate of spending of the rest of the country. So there were now huge differences in spending between McAllen and El Paso in what were essentially identical communities. So Don said, well, you really ought to talk to Atul Gawande. So he dials Atul on his cell phone and hands me the phone. And I say, Atul, there's this thing going on in McAllen and El Paso. And he decided he would write about it. And it was published on June 1st, 2009, The Cost Conundrum, What a Texas Town Can Teach Us About Healthcare. And it was basically the docs treating patients as if they were cash dispensers. And so there was something about the clustering of this behavior within communities. We contrast McAllen, and he did in this article, and I've subsequently spent time in different communities around the country. The values in La Crosse, Wisconsin, the lowest spending place, second to bottom in per capita spending in the country. Jeff Thompson says, we're in a place, we're a community, we're a group of physicians and hospital leaders who care about our community and the financial health of our organization. They're trying to balance both. You can't run a hospital without margin, but they're really committed to trying to make things good for their community. So we came out of that insight with this sense that there are probably 4 major underlying causes of the problems we face in healthcare. Mark McClellan had just left Medicare, actually a couple years before this. He and I had already started to work together with some of our colleagues here and some colleagues at Brookings and some people who are former actuaries for the CBO and Humana, some very smart people to say, how could we fix this thing? But we needed a sort of diagnostic checklist of what are the problems, and then how can we fix them? And we came up with these. The first is that we're confused about what we're trying to achieve. And many of you are here from IHI. I think most of us have come to think the triple aim is the right way to frame it. I would go beyond for specific clinical groups and make sure we pay attention to communities so hospitals don't carve out the really well, make a lot of money on them, and then fail to take care of the disadvantaged populations in their communities. So Mark and I have broadened this to be for patients and communities. The regional triple aim, if you want. Fundamentally inadequate information. The docs in McAllen asserted that they didn't know what they were doing. I don't think that's true. But we need much better information to support improvement and inform consumers. The biggest challenge is this flawed conceptual model that docs come to this work with, which is we think it's about us and visits to us. And the way you produce health is by scheduling your patient back to see you. And if they don't show up, you're relieved, right? Because you have another 20 minutes to or 10 minutes to catch up for the patients, the way you've fallen behind. We manage patients by individual visits. And that doesn't work. So what IHI and others have brought to us are these insights from outside healthcare that say, no, it's got to be something about the system. We need organized systems. Organized care would be the term that Brent James would use, that are accountable for those aims. How those organizations are put together, well, that's what we're going to talk about in another minute. And then we have fundamentally flawed incentives. Fee-for-service, payment for hospitals, separate from nursing homes, separate from home health agencies, reinforces the fragmentation that patients experience. There is no reason for a hospital to talk to a doc, even if the doc is in the hospital. So we need much better, we need to realign our incentives, both financial and professional. And I think our insights from McAllen are this is also something about why do we come to this work? Why are we here? What's our shared purpose? So the Affordable Care Act has created a really very interesting moment that I think will change the conversation that it has changed the conversation that we're all having. There are the new payment models. They're basically 3 fundamental flavors. The patient-centered medical home or new primary care models is one framework. Medicare has launched the Comprehensive Primary Care Initiative. It's actually modeled in large part on the Vermont Primary Care Initiative that has brought public payers and private payers together to create primary care teams in communities to support clinicians to do the things that docs never did, manage population health, reach out to patients. It's a new payment model. It is fundamentally changing the way primary care practices are thinking about their work. My own sense is it's, again, necessary, probably not sufficient, because there are no incentives in this system for the hospitals to talk to the primary care physicians, and it leaves all of the weight of responsibility on the primary care docs to do something about it. So your job is to get the referral back from the hospital. Your job is to make sure the specialist communicates effectively with you. It's probably not quite sufficient. Bundled payments. This is the idea of paying for a hospital stay plus the physician services with a single payment, or some additional post-acute care, or maybe up to 90 days. Brandeis has done a lot of great work on figuring out what those episodes might be, and it's a very important shift to say, oh, if we pay for a bundle or we reward people for providing better care within that bundle, by golly, the hospital's going to have to talk to the docs. And the post-acute care system is somehow going to have to be aligned and coordinated, or there is at least an incentive for people to talk across the boundaries that were created by the fee-for-service payment system. And then there's this thing, accountable care organizations. So let me spend a second on that. The idea began about 25 miles, as the crow flies, about 25 miles from here in Randolph, Vermont. Randolph is a tiny community. We knew all the people there, actually. There are about 3,000 of them. But what you can do if you know the boundaries of a hospital market, you can figure out who all the people are there, and you can figure out what it costs to take care of them this year for Medicare and the commercial payers, and you can project that forward to next year. What inflation rate do you want to use? Well, choose 4%. If they bring their costs down below the target growth rate, they would get a share of the savings. This was just a shared savings model. It didn't get very far. We were 10 years, it was 10 years before our time, before its time. But the notion of defining a population, figuring out a virtual budget, and setting a target payment level started to catch on. Mark McClellan applied it in the physician group practice demonstration when he got to Medicare. And then we started to talk about this idea. It turned out that most docs practice in natural networks around one or more hospitals, referring to, even if they're in fee-for-service practice purely, they refer to a network of other primary care and specialist docs around that hospital. They discharge back out to that network. You could do the same thing as we did in Randolph. You could define the population cared for by those patients and cared for by those docs, and go, oh, we can figure how much it's costing this year to take care of you, and we can project forward a target, give a share of savings. We started to work with consumer groups, AARP, AMA, American Hospital Association, to iterate some ideas around how we might make this work as a pilot. And everyone got kind of enthusiastic. They said this notion of population-based virtual budgets, real or virtual organizations. We got to measure quality because everyone experienced the bad things that happened in managed care. The consumer groups said we need to make sure we have patient choice so we're not locked in by gatekeepers the way we were before. And we have to accommodate diversity. We need to be able to think about this working in Tucson just as much as it does at Dartmouth Hitchcock. In Tucson, every doc is in a 1 or 2 person practice. I think the biggest is 5. So we need to accommodate the diversity of practice settings. The CBO scored the ACO method model as saving money. Uh-oh. That means it's included in the Affordable Care Act because every congressman wants to spend more money on something else. And so if they stuck this in as a national program, it would be included in the ACA. So it was. There are a bunch of, now, the federal programs, there are 3 federal programs that are out there. There are, and the private sector is moving rapidly in this direction. What I want to do to sort of help us think about it a little further, more precisely, is give you an example from Iowa. The Iowa Health System presented it at the Brookings-Dartmouth ACO Learning Network a couple of weeks ago, and has really thought through how to pull this off, I think, quite carefully. This was initially a hospital system. They decided we need to be moving toward patient-centered integrated care. Best outcome, every patient, care coordination, that's a familiar name, physician alignment, employee engagement and excellence, and system sustainability. They have given the contracting responsibility for everything, fee-for-service contracts, to the guy who runs the ACO. And he demanded that when he got there. Because having your foot on the dock and in a new payment model as it starts to pull away from the dock just isn't a lot of fun for a physician leader or anybody in the system, because it's very hard to run 2 business models. So he negotiated, this is Mike Murphy, when he took over their ACO program, he said, I'm going to do all the contracting for all the hospitals, all the physicians. So he's moving rapidly, he can move rapidly to value-based payments, to start to put some start to put some incentives in some of the contracts, but move as many of them as possible to capitation or virtual capitation. And then they're developing organized systems of care. It sounds like Brent James, with a bunch of different capabilities. We've gone, so they've also started to say, oh, shoot, now we have to start paying attention to patients like Kate, when she's in the hospital and when she goes home. So here's a picture of their transition to home team members. There are just so many people involved in trying to figure out how to get patients safely from the inpatient sector to home, because people have various trajectories. It's very much like what Jody was talking about. It's not a simple team. It's an evolving group of people who will be different for each patient, but who very much need shared goals, some understanding of what they're trying to achieve, a whole set of communication tools that's frequent, timely, effective, perhaps accurate. And so they're desperate, and actually are doing an amazing job, starting with heart failure, but then they go, oh, heart failure is just one of our patient groups. Anyone who's in the hospital needs this kind of coordinated system. And the numbers of organizations that are involved around the patient are huge. So it's both an individual communication issue, and it's an organizational communication issue, because not everybody is owned by these organizations. Most of the evolving places, whether it's under bundled payments or under the medical home or under ACOs, there are formal relationships. Those may be better. It may be good to have a contract, but there are lots of informal relationships that people are struggling with as they implement this model around the country. They're in 9 markets, with 250,000 patients. I spent last week, a week ago Monday, with a guy who's running 500 docs, primary care docs in New Jersey, 600,000 patients in the Optimus ACO. So they're starting to move forward. Here's where we were in 2009. Here's where we are now. About 230 of them we've been able to track. We're surveying. We launched a survey of all the ACOs just last week, hoping everyone's going to respond. So far, so good. There are 500 applications at CMS for the January 1st launch of the next round of the shared savings program. So there's a lot happening out there. No one thinks all 500 will be approved. There are a lot of duffers who will come in a year later. But is this just another flash in the pan? So Mike Leavitt, former governor of Utah, former secretary of HHS in the Bush administration, I think he's leading the transition team for the Romney group, spoke at McClellan's and my third National ACO Summit, and likened the current moment for providers in the room as Cinderella at the ball. He said, but there's only a small door, and you're all Cinderella. Your clothes are going to turn to sackcloth, your slippers are going to go away, and not all of you will get through the door to be in this new era of accountable care. So get ready, he was saying. And he said the private sector is going to move this forward much more quickly than the public sector will, but the public sector will be pushing this, because you got to have public sector involvement and private sector involvement. And it's not all going to be ACOs with a capital A, capital C, capital O. It is much more about accountable care. No one's going to get away with fragmented, lousy care that costs too much anymore in Mike's mind. Might this work for patients? A group published, Carrie Kalla here published an analysis of the Medicare physician group practice demonstration. It looked promising. It did save real money for sick patients. The places, Marshfield Clinic, Michigan, that really paid attention, reduced total per capita costs for their overall enrolled population between 10 and 14%. That's $40 billion a year. Most places didn't bother to try, because why would you try to change your physician practice? Physicians, the most intractable culture in the world. If this pilot might go away in 3 years, there's just no reason to do it. So there's some glimmers of hope in this model, at least empirically. But if you look at the models out there of similar systems all around, of people who've taken on global payment with a goal of making care as good as it can be for the patients. This is Marvin Curry. Bob Masters founded the Commonwealth Care Alliance, which is about providing, under a capitated payment, figuring out how to provide the best possible care to the most difficult population. Marvin is a quadriplegic, was living in an extended care facility, pressure sores, multiple episodes of sepsis. 2 years, his wife worried about him dying, every day. He's now been out of the hospital for 2 years, taken care of by a physician assistant, Nina Lev, who's the point of contact to build a complex team around him that meets his needs as they need to meet his needs. And they have a bunch of different kinds of patients, and they assemble different skill sets to make care possible for Marvin. And there's a little, if you go Commonwealth Care Alliance and Google that, and you Google Premier, which is where they were nominated for a prize in terms of quality care, you can watch the video about Nina and Marvin. For primary care clinicians, many of you are probably aware of the patient-centered medical home pilot at Group Health, which when introduced showed that it would, when you get these new team-based care models, it does reduce costs, it improves care for patients, it reduces staff burnout. That's a picture of Harry Shriver, who a year before the pilot put in for early retirement. As soon as the pilot was completed, he said, "There's no way I'm retiring. I'm having much too much fun as a doc. I'm going to stay in this. I'll happily run the practice." He recruited his daughter to join him in the practice as a family physician 6 months later. Sanjeev Arora runs a team-based network of specialists and primary care nurses and primary care physicians across the state of New Mexico that takes care of patients with complex hepatitis C. So using evidence-based practice to have the protocols managed by a nurse practitioner while having a consult done by Skype with Sanjeev and his team allows them to manage these patients without them having to skip a whole day's work to drive 300 miles, or to drive 300 miles across the state of New Mexico. So when Kate was in the hospital in February 2000, this is 12, 11, 10. So the rule, Medicare was struggling with trying to write the rules for this ACO thing. And Kate said, "Dad, accountable care organizations, that's a terrible name. No one wants to be taken care of by accountants. And why don't you call them coordinated care organizations? Why don't you call them coordinated care organizations?" Of course, I emailed Berwick. I said, "Don, you have a chance. Change the name. Change the name." He didn't quite have the gumption. And maybe it is in the legislation. But Oregon has done so. They're calling theirs coordinated care organizations. So, what better place? This conference, the critical success of this whole initiative toward accountable care is going to be about relationships and about coordination. So, gosh, it's up to us. Thank you. I left some time for questions if you'd like.
Yeah, I'd love that. So why don't we open it up? I just wanted to say that I really appreciate you reminding us why we're here today, because one thing we've seen both in the airline and the healthcare research on relational coordination is if cost isn't a constraint, you don't really need coordination. You just do more. If quality is not an imperative, you don't need coordination. It's only when those two are both imperative that coordination becomes critical. And it turns out coordination is a lot about the underlying relationships. And so in the era of accountable care, this is really the time we need to address those issues. So let's open up. I mean, there are people here in the audience and the participants today who've been caring about coordination even in an era when it wasn't imperative because it just seemed like the right thing to do. And now we finally have the kind of, as people said at IU Health when I visited there about a year ago, we finally are going to get rewarded for doing the right thing. And so that can be really empowering. So let's just open it up. And Elliot. Oh.
Happy to answer questions. Some of you probably know much more about this whole thing than I do.
Oh, Chris, thank you.
Hi, Elliot. Thanks for talking to us today. I'm Travis Harker at Concord Hospital. I know each other well. I was curious, since one of the goals was to make accountable organizations fit for across the nation, and when you showed that map where the concentration hosts, I wondered what your thoughts were about that.
Which lives in the middle of There's some wonderful, there are some wonderful ACO. I was going to tease my friend from Indiana where so no. But it is fair to say that the population density in much of the country out there is much smaller than in the Northeast. But I think this is a model that's easier if you're in rated systems. We're actually going to publish an article, we hope in a month or two, that maps not only the hub of these, but the spokes, and it's spread out further. But it is slower in rural areas, it's slower in low-income areas, and it's slower in regions that have low per capita costs, because docs figured that, and the provider systems have figured out that, hey, under a shared savings model, we can make off like bandits if we're starting in a high-spending region. So one of our ACO pilots, who will remain nameless just for the fun of it, find it very easily, sold his business to a national company for $4.4 billion because he thought he has the secret sauce in high-spending regions to take out a lot of money. Just go off? Whoa, yeah, all right. So he has I think it's going to be slower in rural areas, but there's, the FQHCs and rural health centers around the country are really stepping into this model quite quickly. So there's one in northern New Hampshire. There's quite a few out west. I think I don't know. We have to figure out how to help them do it. The advanced payment model that Medicare has put in place will provide capital, additional investments to poorly capitalized practices. So there is a lot to do to get it to spread everywhere. And shoot, it may not work, right? It's going to be about holding them accountable, truly, tracking their performance, being public about what works, and embarrassing those who try to rip off the public. Yeah.
I was struck by your observation that variation had a lot to do with the propensity to do something when you don't know what to do. And then I think you inferred that becomes the norm. So it becomes enculturated in the culture in a medical. I'm wondering what you've learned over the years about that observation and what you've seen about changing kind of cultural propensity.
Well, first, culture's really hard to change, as you probably know better than I do. But I've spent a bunch of time now with the leaders of Optimus Healthcare, the most fragmented, highest cost, poorly performing healthcare system in the country. That is central New Jersey. Multiple specialists. If you look at the Dartmouth Atlas on end-of-life care, they're pathetic. I think would be the technical term. They're engaging physicians around the shared purpose of being able to take great care of their patients. And it's working. So the 500 docs, 550 that Jim Barr and Tom Kluse have put together are suddenly discovering what fun it is to practice when you are supported to take good care of your patients. So I think the tools for changing the cultures of overuse are multiple, but it's going to be something about physician leadership that gets people to reconnect with their values. It's going to be something about a payment model that rewards them that doesn't harm them for doing so, and the support that makes it possible for them to change. And so I'm modestly optimistic.
I want to follow up Kurt's question with a little more pointedness, maybe. In McAllen and other places, and of course in all of our communities, we have physicians who are doing things that don't speak well to the professionalism of medicine, otherwise known as bottom feeders, justice side of criminal, upcoding, et cetera, et cetera. What's your answer to what we should do about that?
I'm going to turn this to Tony in later section. I think this is about how we have conversations about what's important. When we're willing to speak about what we observe, I was having this conversation with my orthopedic surgeon in a town in upstate New York. It's really hard, and I don't see, I mean, I think there will probably be several strategies. One is transparency. That'll make them the outliers. The second is no one will want them in their network when someone's trying to figure out a network and they'll be out by themselves. Third is if they want to be part of the network or already in your network, this is what leadership is. You know, it's feedback and management. Saying if you're not with us, you shouldn't be here 2 years from now. We'll help you find a new job. Stan.
I'm not going to give you my age, but I was involved in the initial HMOs legislation. It was a great idea. I was involved in deciding to develop HMOs in this country. And it was, over 29 of these group practices around the country. And, as we start to evolve it, it'll provide a base, as you know. And as we start to evolve it, all of a sudden we said we could pass this legislation, and all of a sudden the new HMO evolved. It was in drag. It was all insurance companies, large insurance companies wanting to say, hey, we can do this. We want to make a lot of money, and the whole concept fell apart as a result of that. So you started off, as you described, in the '80s, talking about Brandeis, Vermont, in this small area, and now we're talking about this big, huge, these large organizations, for-profit organizations, coming into the ACO world. And what we lost in the whole HMO movement, could we, the fears here now?
Absolutely. This is a very vulnerable moment. And so it's, I think there are three strategies at least that we're pursuing. One is to create local transparency about total per capita costs on both the commercial population and the Medicare population, so that you see both in terms of price and in terms of volume, so we know who's ripping us off. That will create a conversation among payers in the communities about which organizations are taking advantage of their pricing power to steal from the public or steal from both locals and federal publics. I think the second strategy is the strategy that's in this room, which is having serious conversations about why we come to this work. And the more of us are willing to say, no, this is an important moment, and we need to make these organizations work. I look in Boston, and I'm modestly encouraged. Steward, as much as they're trying to develop a model that will make a lot of money for their investors, it's a model that could support the disruption of the typical for-profit health systems, for-profit, even if they're not for-profit, that are not paying attention to the needs of their communities. So the second strategy is let's engage in conversation. And then, the third, will be how can we get broader communities to take responsibility for the health of their community populations, which is the hospital physicians within those markets. And so the Rethink Health initiative that many of you are now aware of is, trying to build local governance capacity in multi-stakeholder coalitions, drawing on the insights of Eleanor Ostrom and others to say, we have to pay attention to the health of our community and our healthcare systems, and that's up to us, the broader business community and others to engage in that. And then so it may not work. We may blow it up again. But we're in a slightly different place. We have much better measures of quality. They didn't measure quality at all. This is emerging in many of the markets more as a partnership than it is as a shifting risk from payers to provider groups who had no competence in managing risk. Many more of the models are actuarially semi-intelligent, so they're putting the right amount of risk on the providers. But this is a complex system, Kurt.
So my question pertains to this challenge that I have in trying to think of the ACO model and the communities that organizations serve in a visual way. Like, I tend to try and draw some shape around what that community is, and that works for many parts of the country. I live in the Philadelphia area where...
Good luck with that.
I know, and I think this could pertain to other big cities with academic medical centers where, they don't really have a community that they're serving. It's, you know, pulling from here and pulling from here. So how do you see this playing out in those big urban areas?
It will be, you know, there are a couple of ways. One is that the cheap, good places will win, and some of our academic medical centers will close. The other way, and that'll lead to all sorts of disruption and people being laid off. And so one model is the market will work, and it'll be really ugly. The second model, which is harder to imagine it ever working, is the polycentric governance model that Eleanor Ostrom and others thought about for commons issues, where if you get a multi-stakeholder coalition, as in Cincinnati, where the CEOs of the major employers are now involved in thinking about the health of their community and the healthcare systems, you could actually imagine conversations where they say, you know, we really don't need all 22 of these hospitals. We have some pretty old plant that someone would want to rebuild if this were the 80s, but let's not rebuild it. Let's close those hospitals, let's turn them into apartment buildings for the uninsured or for homeless, or let's use them as post-acute. It is, can we do, I mean, what Ostrom observed in Los Angeles with the problem of water incursion as everybody overpumped because they had the incentives to do so, was that they were able to create a community governance structure across town boundaries, across county boundaries, and solve over about 20 years what was a very complex problem by developing some shared purpose, developing trust, and then starting to take the small practical steps forward that said, oh, well, we're going to need to keep track of how much water everybody's taking out of the water table. First step. Then was, oh, you're taking a lot, and we're going to tax people who take more than so much to get a water district, you know, defined that's broader and can tax people. So those are the two strategies I can imagine. It will be interested in Philadelphia and Boston, whether there's we know that Partners wants to be the last man standing. I don't know whether someone's going to grow up and have, step forward and help support the grown-up conversation. That's probably up to the people in Boston.